So the colic is, as everyone knows, that colic is an emergency. However, it has been seen that 95%, I'll say 90 to 95% of the colic, they are non-surgical. So they are basically non-surgical. It means they are medicinal in nature and they can be taken care with the medicine without any problem. So we need to recognize those 5 to 10% of the cases which are non-surgical, which are surgical in nature. And so there are a few simple tests which I will be telling. So tomorrow I'm going to tell you about the medicinal problem, medicine management, as well as the surgical management. So 80% of the colic, they are idiopathic. Sometimes the signs are there, but we don't know why this is happening. So let's see about the etiopathology. Like what is the how the colic happens. First of all, it can happen because of the three reasons. Either it can be because of the partial obstruction, or it can be because of the complete obstruction, or it can be because of the strangulation. So partial obstruction, if you see like over here, I have depicted one obstruction which is partial, which is not complete. Some of the ingesta and gas is passing through the intestine. So this such type of obstruction, they lead to mild colic, mild or moderate, maybe sometime moderate. But so if there is a complete obstruction is there, so there you can see the obstruction is complete. The intestine, which is oral, towards the oral side of the obstruction, that will be dilated, and the obstruction which will be aboral to the intestine, which will be aboral to the obstruction, that will remain collapsed. So because of this distension, so there will be pain. And third, which is very emergency, I'll say that only surgical conditions surgery can take care of such conditions. So here in complete obstruction, moderate to severe colic can happen, but in strangulation, it's a very acute, I'll say, colic is there. And in that case, there is strangulation. You can see the intestine strangulation is there, and the blood supply that is hindered, that is not complete, and there is a dilatation, complete dilatation is there of the intestine, complete obstruction of the intestine is there. So such type of colic, that can lead, that's a life-threatening problem. So if we don't take care of such type of problem on time, then it can lead to death of the animal. So that's why if the strangulation happens, I'll tell you few tests which will help to diagnose the strangulation, if strangulation is there, or the horse is suffering from life-threatening problem, then those tests can be performed very easily. So if we come to the pathophysiology of the pain, we can see this is a transverse section of an intestine, which I am showing. So if there is it can be because of the distension of the intestine. Stretch receptors are there in the intestinal wall, which when stretch leads to pain. Or sometimes it can be because of the inflammation as well. Inflammation of the wall, you can see thickening of the wall is there, so that can also lead to pain. Or there is ischemia, bluish wall, you can say ischemia of the intestine is there, that can also lead to pain. So this third category is really very risky. So we have to identify this category as quickly as possible, so that we can perform the surgery and we can refer to some surgical facility and we can save the animal life. Then if we compare, this is a comparison of the digestion. If you see the last column and the second column, you can see if you compare 70% of the digestion in ruminants, they take place in the stomach, means 4 part of the stomach is there in ruminants, and 70% of digestion that takes place. And only like large intestine, only 7% that takes place. And if you look into the equine, you can see hardly only 1/10 of digestion that takes place in the equine stomach, but you can see 16% in cecum and 45% in large intestine. Large intestine means colon. Colon, I'm talking about the colon, and colon is the main part of digestion. So it has been seen that the part of the GIT which is more involved in digestion will be more involved in anomalies which can lead to colic. So you might have an experience that in ruminants, most of the problem, GIT problem, is related with the stomach, rumen reticulum, omasum, abomasum. But here in equine, most of the problem that will be related with the cecum or with the large intestine. Sometimes the small intestine can also be affected, but occasionally stomach can be affected, but that may not be a surgical, like if proximal enteritis is there, so that can lead to gastric dilatation. So that is a condition which the stomach can be dilated. But most of the conditions, they happen in this part of intestine. So now comes to the applied anatomy of equine GIT. The main thing which I want to discuss, that each and every veterinarian should know about the equine GIT, because there are different points are there, and different points of the intestine, they behave differently during colic, because there are one point is there small colon, we call it small colon or descending colon. So there the fecales are very common. There the foreign body, which the sometimes mules or donkeys or some horses, they eat the foreign body, especially the plastic. Now there is a lot of plastic is there around and ropes are there. Sometimes horses, they ingest, and they likely to go and stuck into the small colon. But if there is a impaction is there, because in our country, especially in North India, where I'm speaking right now, so there is a habit of giving a lot of wheat straw, especially in the winter season when green is not there. So those wheat straw can sometimes lead to impaction, and that impaction is most commonly found in pelvic flexure or in cecum or in transverse colon. So that's why applied anatomy is really very important. Like if you know about the anatomy of the equine GIT, then you can easily diagnose that particular condition, that part of intestine having a particular condition. Let's come to, so I have this slide which will show you the GIT from all aspects. So I'll be, this one is from the lateral one, this is from the lateral, and this is all GIT. So I'll be discussing, this is from the top. If you view a horse from the top, so this is from the top. And here, I'll be starting over here. This is the stomach. Okay, so this side is the head, and this side is the tail, and this one is the right side, and this one is the left side. Okay, so stomach, small intestine, ileum enters into the cecum. So cecum is basically a comma-shaped structure, and it works like a rumen. In a ruminant, cecum works like a rumen. It's called a hind gut as well, because it has a lot of bacteria which digest the cellulose, and so it works like a rumen. So it has a capacity of around 25 to 30 liter. So it's a comma-shaped structure, and it is so first colon. So cecum, ileum enters into the cecum, and the first part of the large colon. So this part, and this part. So these four parts, they are called large colon. Okay. So the first, this part is called right ventral colon, because this cecum is always on the right side. Everyone knows cecum is on the right side. So first part of the large colon, which starts from the cecum, is the right ventral colon. So this is a right ventral colon. So this right ventral colon, so it travels like on ventral aspect of the abdomen and go cranially. Here is the diaphragm. If you see, here it will be the diaphragm, and so it turns near the diaphragm and go towards the left side. This one. So the left side, this is the left ventral colon, and it travels towards the pelvic region. So here will be the pelvis. Pelvis will be somewhere here, and travels towards, and just cranial to the pelvis, it turns on itself and form a hairpin-like structure. If you see, it's a hairpin-like structure, and it forms left dorsal colon. This is left dorsal colon, and left dorsal colon again travel cranially and comes again near the diaphragm and turns and towards the right side and form left dorsal colon. So this is left dorsal colon. This is the left dorsal colon, and see the left dorsal colon. and it transfers from right side, the intestine go towards the left side. It is called transverse colon. So this transverse colon transverses towards the left side, and again they start the small colon. This is the small colon, or even we call it as a descending colon, small colon, or even descending colon as well. So if you observe this intestine of of an equine, you see the circulation. If you can appreciate these circulations are there. If you see the circulations, so these are the circulations. These are called hostra, and these circulations, they are present in the cecum and only in the ventral part of large colon. The dorsal part of the large colon doesn't have circulations. So that's one of whenever we perform the surgery, or even at the field level, if you want, if you perform any post-mortem as well. So, you can diagnose the ventral part, right ventral or ventral part, ventral colon and dorsal colon by looking at the circulation. So circulations will be present in the ventral part of the colon and will be absent in both right and left dorsal colon. And again, the transverse colon does not have circulations. And next circulations, they will start from small colon or descending colon. So this descending colon has circulations as well. Here, if you come over here, you see this is the cecum. Okay, from cecum, right ventral colon starts, turns, and this is, and here is the pelvic flexure. If you see, here is the pelvic flexure. This one. So this is quite near. If we perform the per-rectal examination, we can easily palpate the pelvic flexure. So this is a structure which is highly, like when we do per-rectal examination, palpation of this structure is very important. So if you observe over here, if you see here the right ventral colon, when it turns and goes and forms the left ventral colon, and again over here, if you see the diameter, here the diameter will be around 25 centimeter, 25, and sometimes somewhere over here it is 30 centimeter. But when it forms the pelvic flexure over here, pelvic flexure, the diameter turns out to be only 10 centimeter only. Such a 1/3 decrease in the size of the diameter of intestine at the level of pelvic flexure. So that's why this is the most common site of obstruction in case of colic. And second most, if you observe, if you appreciate over here, here to the diameter of the right dorsal colon, this is right dorsal colon, it is around 30 centimeter. And when it forms the transverse colon, this is the transverse, you can see it's a transversely going from the right side to left side. So that's why it is called transverse colon. Here too, it turns out to be around 12 to 13 centimeter. So this becomes the second most common site of obstruction. So that's why we need to see these 2 points whenever we see, we need to diagnose where the obstruction can happen. Then if you see from the top, if you see like over here, so from this is right dorsal colon, and this is transverse colon, and from here is the small colon. You can appreciate these circulations. So these circulations can be there. And whenever you do a per-rectal examination, and you might be having experience in doing per-rectal examination, just cranial to the pelvic inlet, so you found the fecal balls are there. So those fecal balls which you are palpating, they are present in this small colon. So small colons, they have a lot of fecal balls are there, which will be voided ultimately. And now comes to, this is from the ventral aspect. When we see from the ventral aspect, this is a picture from a horse when we did the postmortem. So ventral aspect, this is the cecum, it's a comma-shaped structure. From cecum, this is a left ventral colon. Then this is a sigmoid flexor which turns, and this forms a right ventral colon. You see the circulations from the ventral aspect as well. Okay, and this is diaphragmatic, this is left dorsal colon. So this is the DC means descending colon, or it's a small colon. So we'll discuss this slide later on as well. So here you can see this is cecum. So whenever we perform a surgery, so this is just for your knowledge, like if whenever we perform the surgery, the first thing which comes out through the incisional site, that is always a cecum. It's a comma shaped structure. So cecum is attached with the ileum, and cecum is attached with the right ventral colon as well. So the cecum is very important part whenever we need to perform a surgery. So when we take out, so cecum organ is a guide. So whenever we want to move towards the right ventral colon, then we follow this ligament. This is called cecocolic ligament, and we follow this one. And this is ileocolic ligament, blue arrow. So this is ileocolic. When we follow this one, then we go towards the small intestine. Here too, you can see the small intestine. This is ileum. Ileum part. This is ileum, and this is right ventral column. Here too, very important structure. This is pelvic flexure. Pelvic flexure, which I discussed. So it's a hairpin-like structure. Here you can appreciate the diameter from here till here. The diameter is huge. 30 centimeter, 25 to 30 centimeter, and it's a left ventral colon. And here you see left dorsal colon. See the diameter, only 10 centimeter. So the ingesta, whatever the ingesta comes over here, okay, so it passes through a very narrow passage. So that's why chances of obstruction is very much there at the pelvic flexure. PF is pelvic flexure. So at the level of pelvic flexure, the chances of obstruction is there. So that's why, because of this structure, horse is very much prone to colic. So here too, this is a structure, anatomical structure concentration. So I just want to show you the small colon. If you see the small colon, circulations are there. Small colon circulations. These are the fecal balls are there. And if you want to differentiate between small intestine and small colon, so you should see the mesentery. So mesentery of the small colon, it has a fat. It has a mesocolon. We call it a mesocolon. So this mesocolon, it has a fat, but the mesentery of the small intestine, that's a transparent. So why I want to tell you, because the size of the small colon and small intestine is almost the same. One can confuse that whether it's a small intestine or whether it's a small colon. If it is small intestine, see the mesentery. And second, there is a band is there. This black arrow. If you see the black arrow, this band is there. So this band is absent in small intestine and is present in small colon. So here, if you see over here, so if you can see, appreciate that there is a fecalith is there. Here is the fecalith. So sorry, here is the fecalith. So if you see the small colon, this small colon is collapsed, and this small colon is distended with the gas. It means this is a part which is having obstruction, and the proper ingesta is not moving forward towards the aboral side. So that's why obstruction is there, and it leads to colic. Now comes to the first thing is this is the again this is the pelvic flexure, left ventral colon, left dorsal colon. So most common site of infection is the pelvic flexure. And second most common of site of obstruction is the transverse colon. When right dorsal colon enters into the transverse colon, this is the second most common site of. And third most common site of obstruction is the small colon. Small colon means like the common site of obstruction due to the fecalith, due to the foreign bodies, and due to enterolis. Enterolis are basically the stones. So fortunately, in our institution, we have some we come across some horses which have enterolysis there. It's a really very hard stone, which is formed into the intestine, especially in the horses which are fed on alfalfa grass, or which are a habit of eating sand or soil. So they're likely to form enterolis. So those enterolis, they stuck in small colon. And whatever, if the animal is having, especially the mules and donkeys, they have the habit of eating foreign bodies, and even some horses as well. We come across some horses which can ingest foreign bodies, because a lot of plastic is there, and those plastics and ropes, they're likely to stuck in this part. And this is the third most common part of obstruction. And the cecum, this is the cecum. If you see this, we have removed the cecum. It's a common same structure, and this is the fourth most common site of obstruction due to impaction as well as gas. Gas colic can be there. So this is the fourth most common site of obstruction. And sand colic. If a horse is having a habit, or especially the horses which are in the desert areas, so if they can develop the habit of eating sand, and that sand and the settle down in the right ventral column. This is the right ventral column. Circulation is there. You can see the circulations. So ventral column will have circulation. Again, I am repeating, dorsal column will not have circulations. Then comes to these are the intestine. Intestine can be affected because of intussusception or because of ascaride infection is there, because of the worm infection. So that ultimately lead to obstruction of small intestine. Now looking at the if we look at the etiology, lot of etiology I already discussed. So there is a few conditions are there. It was called pedunculated lipoma. This is a disease which is more than 50 age horse. This condition you will not find in a young horses less than 10 years of age. So pelviflexure transverse colon infection that can happen in any horse which is more than 3 years of age. Fecolits and foreign bodies can happen in small colon. Sand colic, which I already discussed, and enteroliths, this can be large colon displacement, very important. So this is a condition which is per acute in condition. We have to go for surgical intervention immediately if animal is not responding to treatment. Large colon displacement is there. The colon, large colon means out of again I'll be. So out of all large colon, this is large colon, left ventral, left dorsal, right ventral, right dorsal colon. So this left side, this is the most mobile part of large colon. Left side, pelviflexure, left ventral, left dorsal, most mobile. So this mobility can lead to problem in horses. Sometimes this mobile portion can go dorsally and settle down in between the kidneys and spleen. I'll show you this the diagram, that one as well, and that leads to left dorsal. And sometimes it can turn towards the right side, means it can go towards the right side over here. When it goes towards the right side, that leads to right displacement of large colon. So that's also an emergency condition as well. Then flatulent and gas colic, which is very common in cecum. The gas that accumulates into the cecum. Spasmodic colic is there when there is a increased peristaltic movement of the intestine. Intussusception can be there, especially in the small intestine. And there are some reason, non-GIT reason is there, especially when especially in mares which are advanced pregnant, last quarter of pregnancy is there, and when there is a torsion of uterus is there. So that is a non-GIT reason, most common non-GIT reason for advanced stage pregnant mares. So we are performing a number of such type of surgery. We have to do the cesarean immediately, because otherwise it can be a life-threatening for the mother and for the foal as well. So there is another condition, like if there is a cystolysis formed in the urinary bladder, that is also a non-GIT, and sometimes cystitis can also lead to colic. That is a non-GIT in origin. So if we see the bands, if you see the circulations, I'm repeating the same thing. You can see the circulations are there in the cecum, right ventral, and left ventral part of the colon, and there is no circulation over here. And again, the circulation that starts to some extent in transverse colon and most prominently seen in small colon. So this is only I just want to tell you the thing, like if you want to perform a surgery, or surgeries, if you are in the middle of surgery and if you want to diagnose the part which is involved in impaction, so these circulation will help us to diagnose. Then it comes to the history and clinical signs. Now comes to the diagnosis part. History, as everyone knows, the most common like sign is pawing, means the animal that start rubbing the ground with its paw, like, and laying down, stretching, and it adopts a posture of urination. Lot of, you can say that, like, there is a sweating is there, laying down, looking at the belly, kicking the belly. And this is when there is injury marks on the prominences. This is tuberculosis and over the eye. It means there was a severe colic and animal has rolled a lot. This led to the injury on the prominences. So these are the all signs. And even Flayman's behavior. If you see the Flayman's behavior, that's also a sign of colic in horses. So second thing which we should see about the distension. See the two horses. So which we did the surgery on these two horses. And this horse has a mild, moderate, I'll say moderate abdominal distension is there. And in this horse, you can see there is a severe abdominal distension. Now, etiology is different in these two horses. Here, it was a transverse colon infection was the cause. Here, it was large colon volvulus was there. Means large colon means I'm talking about the most mobile portion of the large colon, which was the left ventral and left dorsal and pelvic flexure, and that was having a volvulus. And volvulus was there, and that led to a severe colic. When we opened up, it was all necrotic, and we have to put it down. So always indicate, it means there is some strangulation is there. Mild to moderate, it means there is some infection is there. So mild to moderate distension, especially in the cecum. So in those horses, though the colic sign, they remain for a longer time. Chronic colic will be there. But if there will be a volvulus will be there or strangulation will be there, like in this horse, so that horse will have a peracute colic. So we have to perform the surgery within few hours, otherwise animal is going to die. Now comes to physical examination, very important part of diagnosis in the diagnosis of the colic, like physical examination. The first thing we should see about the CRT. CRT means, like, on the corner incisor, press the mucosa and see how much time it takes to refill back. So if it's a less than 2 seconds, it means it's fine. If it's a more than 2 seconds, it means animal is going towards shock. Okay. So now comes to the normal, like this is a normal pale pink, moist mucous membrane. This is a normal one. And this is the pale mucous membrane. This might be because of either the shock is developing or animal is feeling a lot of pain. And now it's injected. See the difference. This and this one. This is more reddish in color. It means endotoxemia is developing. And over the teeth, if you see over the incisor, the line is there. So red line is developing. This sign. This is called toxic line. See the toxic line. If toxic line is developing, it means animal endotoxemia has started developing. And see the color. This is a violet color. See the violet color of the mucosa, and this indicates some strangulation is there. And the same reddish line will be purple over here. See, this is a purple over here. So over the teeth, if you see the purple line, it means some strangulation is there. So we need to go for immediate treatment. So third eyelid, if you press the eye, even the third eyelid, you can see the third eyelid and see the color of the third eyelid, whether it's injected or it's endotoxemic. So the best will be to see the oral mucosa. The oral mucosa is the best indicator for the condition which is going inside, prevailing inside the animal. Now see the palpation of the facial artery. This is facial artery. Here you can see the facial artery. Here this is a transverse facial artery. Both you can measure the heart rate as well, even with the help of stethoscope underneath the triceps muscle. If you place the stethoscope, you can easily auscultate and you can estimate the heart rate. Measuring the heart rate is a very important parameter in a colicky horse. So if you measure it properly and see how much is the heart rate, then you can easily diagnose whether this horse is responding to the treatment or whether it's deteriorating. So heart rate is a very important factor for diagnosing the prognosis of that particular case. Just for example, if the heart rate is mild, less than 40, it means the colic will be mild. So we should continue with the medical treatment. And if it's a 40 to 60 moderate, we can still continue to the medical treatment. We can medical treatment I'll be dealing with tomorrow, then the tomorrow webinar. So the medical treatment we can continue even if there is a 62, and we can monitor it further after the medical treatment, maybe depending upon how much severity is there. If the colic is severe, then we have to note down the heart rate after maybe 1 hour, 1.5 hours. If it's a mild colic is there, then we have to measure the heart rate maybe 6 hours or 12 hours or sometime after 24 hours. So if the heart rate is stable, it means animal is responding to the medical treatment. But if the heart rate is going up, it means if it is 60 to 100 going up, it means a serious thing is now happening inside the body. Then we have to think, we have to shift the animal to some surgical facility. If it is going more than 100 heart rate per minute, it means it's going towards a bad prognosis. So the heart rate, that's why the measurement of the heart is really a very diagnostic parameter. So there are some conditions are there. If there is a pelvic flexure obstruction, which I told you, pelvic flexure, the same pelvic flexure is there in front of you. So this is left ventral because circulations, this is left dorsal, pelvic flexure is there, cecum is there. So if there is a mild obstruction is there in the pelvic flexure, the heart rate remains between 40 to 50 beats per minute, and pain that can be mild, and animal will be dull and can be off-feed. So, and even in small colon obstruction, I showed you that there is a terminal portion after transverse colon comes small colon, and small colon can have fecalith. So if the fecalith is there in small colon, so that also shows the mild form of colic, and heart rate remains between 40 to 50. And if there is strangulation is there, then heart rate that always likely to go up to 90, or sometime it cross 100 as well. Pawing is there, rolling is there, mucous membrane will color will turn towards the violet color. Then there will be toxemic lines over the incisors. So now auscultate. This is also a very important part of the diagnosis. Auscultation or evaluation of the gastrointestinal means this is called to evaluate the borborygmy, means the intestinal sounds. If so, the right flank region, right flank region is the region where the ileum enters into the cecum. So when ileum enters into cecum, so there are gushing sound of the ingesta is there. And if you hear, there is 1 to 2 sound is there in 1 minute. This is a toilet flush like sound, means like some drain pipe is there and water flows through the drain pipe. Similar sounds you can auscultate over here, and that should be present. And if it should be 1 to 2 sounds per minute, and if it is not present, it means stasis is developing, and it means intestinal peristalsis is not proper. It means obstruction is there. And here you can auscultate the right lower abdomen of the large colon, and this one we can auscultate the left flank region for the left dorsal part of the large colon, and here we can auscultate the intestine, small intestine as well. So intestinal sound. So this is very important. So auscultation of the gastro. So if it is absent, it means 0 in 1 minute. 1 to 2 means 1 is reduced, and normal should be 2 sounds per minute. Increased, it means more than 3 per minute. It means there is some enteritis is there. Salmonella can be one of the common cause of increased borborygmy. To another very diagnostic part, which is called nasogastric intubation. Hello. Hello.
Yes.
Yes. Is it okay?
Yeah.
Okay then. Yeah. Nasogastric intubation is another diagnostic tool, I'll say. Every veterinarian should have a nasogastric tube if they want to perform, practice on horses. So this is a very handy tool, and especially like if you perform the nasogastric intubation, do the nasogastric intubation, then you can save the animal life as well. So how to perform, I'll show you some pictures on that. So measure up to the pharyngeal region, mark this the nasogastric tube, and you then put your finger into the false nostril. Okay, let the lubricated, this is a lubricated nasogastric tube. Let it enter into the ventral meatus. See the position of the head. It should be 90° to the neck region. It should not be straight. It should be 90° whenever we are passing. And once we reach into the pharyngeal region, start blowing the air into the pipe so that it will induce the swelling reflex, and animal will likely to ingest the nasogastric tube if you blow the air into. So automatically, otherwise the chances are there that nasogastric tube can go into the air passage. Okay, so whenever we do the nasogastric and see if there is a nasogastric reflex is there, and if the reflex is there, how much is the reflex? Is it less than 2 liter or is it more than 2 liter? And what is the pH of the nasogastric reflex? And what is the color of the nasogastric reflex? So if it is more than 2 liter, it means there is a large colon obstruction is there, some obstruction is there. And see the pH, if it is coming from the normal pH is 4 to 6, and if it is from small intestine, it is 6 to 8. 6 to 8 means if the pH is from 6 to 8, it means small intestine contents are coming. But if the pH is towards alkaline in nature, it means contents are coming from the large intestine. So that it means there is some obstruction is there. And the color, another thing is, if the nasogastric reflex is more than 4 liter, then don't remove the tube. Keep the tube into the stomach for at least for 1 day, 24 hours, 30 up to 48 hours. Keep into, so that there might be need to deflate the stomach repeatedly. Rather than putting the nasogastric tube repeatedly, you can keep the tube into the stomach for 48 hours. And another thing is, like, if you want to transport that animal to the surgical facility or to a university hospital or somewhere, even at that time, you should keep the nasogastric tube in situ into the stomach, because during transport there is a lot of gastric fluid is formed, so that it can be drained and gastric rupture can be avoided. And it's a handy at the time of surgery. Whenever we perform surgery, we give a general anesthesia, animal falls down, and rupture of stomach can be avoided if there is a gastric tube is there into the stomach. Now comes to another third portion. So we have discussed about the sign, we have discussed about the auscultation of the abdomen, we have discussed about the nasogastric intubation. So these three things, they will give you a fairly good idea that what's the problem is there. Another thing is, which I want to discuss over here, that if the reflex is coming from the nasogastric tube, it's not in all the colic horses will have a nasogastric, it's not like that. Some of the horses which have a complete obstruction can have nasogastric reflex. If the nasogastric reflex is there, then don't put any paraffin or any medication into the stomach. Further, it can lead to dilatation that can aggravate the colic. So if there is a reflex is there, so you should never put any medication or medicine, or especially the paraffin, into the stomach. So now comes to the rectal examination, very important tool for the veterinarian. So the first thing is over here. So this is all drawing by one of my student. So so you can say, so whenever we do the rectal examination, your hand should be properly lubricated. The rectum of the horse is very fragile, and if you if you put the hand without lubrication, that's a really very painful for horse. And second thing is, always paint some lignocaine jelly. Paint some lignocaine 2% lignocaine jelly on your hand, so that's going to desensitize and will provide local analgesia when we perform the rectal examination. So this is the pelvis, and this is the pelvic flexure. You see, it's quite near to each other. So when you will put the hand, and so next slide, I am going to tell you about that thing as well. So over here now this is the slide. You are looking from the front, and the examiner is entering from the behind, and so the examiner will palpate the pelvic inlet. This is a pelvic inlet. Okay, so when is a pelvic inlet, just cranial to the pelvic inlet towards the left side will be the pelvic flexure, towards the left side, and towards the right side will be the cecum. Okay, so the first structure on the left side near the pelvic inlet will be the pelvic flexure. So palpate that pelvic flexure. So okay, so now the hand of examiner is over the pelvic flexure. See how what's the structure, how like big the pelvic flexure is there. So it should not be bigger than your hand. And if it is a bigger than your hand, it means there is some obstruction, there is impaction, and even it's a doughy condition. Like it's a hard. You can easily palpate the pelvic flexure. If it's a hard, it's a distended. It means there is some obstruction is there. Then proceed further over the left dorsal colon. This is left dorsal colon, and left dorsal colon you can palpate the left dorsal colon. If there is obstruction of the pelvic flexure is there, then chances are there that left dorsal colon is also impacted. Okay, so proceed the hand further, and you can even palpate the spleen on the left side. On the left side, spleen can be like just lateral to the left dorsal colon. Spleen can be palpated, and this is splenic ligament. This is nephrosplenic ligament. This is a left kidney. So nephrosplenic ligament, you can even palpate the caudal aspect of the left kidney as well. So why there is a need to palpate the spleen and left kidney and the nephrosplenic ligament? Because there is one condition is there which I told you, that left dorsal displacement of large colon. Left dorsal displacement means what happens, that this is left dorsal colon and left ventral colon and pelvic flexure that travels towards, here is the body cavity, means this is the abdominal, lateral abdominal wall. So it travels this structure that travels lateral to the spleen, in between the body wall and the spleen, and comes over here and comes over, it comes over here and rest over here. So when the structure that comes over here and start rest on the nephrosplenic ligament, this is called the left dorsal displacement of colon. So if you are in between the spleen and the kidney, if you are able to palpate some intestinal structure over the nephrosplenic ligament or some intestinal structure, then it means it's a left dorsal displacement of colon. So this is how we palpate the caudal pole of the left kidney. So then we go towards the right side. This is the right side. So cecum is there. So yeah, I told you the cecum has circulations. These are the Hofstra or circulations, and it has a band as well. This is a band, and you can easily feel the band. So this tenseness, if the band is very much tense, it means cecum is impacted or is having some gas is there. So gas colic is very common in cecum. Gas infection very common in cecum. So if the tenseness of how much tense this band is, more the tense, it means more infection is there. In a normal cecum, the band, you can't appreciate the tightness of the band. So the more the tighter, it means cecum is involved. Now comes to the another diagnostic test, which is called abdominocentesis. It can be done at the field level. So linea alba is the most common site where we can do the abdominocentesis, and abdominocentesis should be done at the most ventral aspect of the abdomen. So it's almost near the umbilicus. So EDTA tube can be used for the collection. So we can perform few tests on these abdominal fluid. Either we can perform the cytology, or we can estimate the protein level, or we can even estimate the lactate as well. So lactate is very important parameter which can be done in any human lab. you can send to any human lab and tell them that I want a lactate level. And if the lactate level of the peritoneal fluid is less than 1 millimole per liter, it means it's fine, normal. But if it's a more than 2, more than 3, or more than 5, it means okay. So normal fluid urine like normal it's peritoneal developing infection is there, or if it is a brownish, it means the gastric rupture or some intestinal rupture has happened. So cytology, the cell cytology can be done. Even veterinarian, which is having a microscope, that can make a slide and do the staining, genes of staining, and perform the and see how much nucleated cell is there. If it's less than 7,500, it's fine. If it's more than, it means peritonitis is developing, or some reaction is there to some strangulation is developing. So this is, I just want to show you, this might be what you can see in the cytology. Day 1, some cells, if the cell keep on increasing, it means peritonitis is developing. But if simultaneously the cell is decreasing with time, it means that animal is responding to the treatment. But one thing you must see, if it's a matured, hyper-segmented neutrophil is there, it means prognosis is fine. But immature neutrophils start appearing in the abdominal fluid. At the time of, if you want, when you perform cytology, immature neutrophil is there, it means prognosis is not so good. It means body is reacting to very fulminant infection. Now comes to the blood examination. So that was about the up till abdominal synthesis. Now comes to the blood examination. 3 tests: 1 PCV, total protein, serum lactate. Serum, that was I was talking about. That was the abdominal fluid lactate. I'm talking about the serum lactate. So see the level of serum lactate. So these 3 tests can be done at a very like in any human lab. Even if you don't have a like facility for the human lab, you can send. And these 3 tests, they are very much diagnostic for the colic. They can tell you a lot of things, what's going on inside the body of the animal. And TLC can also be done simultaneously to see if there is some infection is there simultaneously. So peritoneal fluid, which I told you, there is another test is there, which is called serum creatine kinase, which can be optional, which will tell you that how much muscle injury is there. That tells you extent of the colic. If the colic is there, animal is kicking the belly, laying down, then this level is going to go up. So it's an optional. So depending upon the severity of the colic, repeat these tests along with heart rate and other physical examination finding after some interval to judge the response to the treatment. Just for example, a horse is there which has presented to you for a colic, which is having a heart rate around 55. And you started all those tests, you did the physical examination, you found heart rate is around 55, mucous membrane color is not so bad, so it's fine, it's not so much injected, and you found is there, and you started with the treatment, and by the time I perform these tests and see what's the value, these 2 values, PCV as well as total protein, that will tell you about how much fluid you need to give. I will show you the chart. So based on the PCV value, based on the total protein value, you can estimate how much fluid need to be given that particular horse. Okay, so so that and you start with the treatment, and after some interval again perform the physical examination, again perform these tests, PCV and total protein. See which way the horse is going, whether it's worsening or it's stable, or is it responding to treatment and his heart rate is going up, down. it means your treatment is fine. Now you can continue with the treatment. But if the horse, which was having a 55 heart rate and is approaching towards 70, 80, it means in spite of the treatment, up to 80 it's fine, means you can continue. But if it's approaching more than 80, it means you need to think about shifting this animal to surgical facility. The serum lactate, this is a very important test to tell us about how much necrotic, septic changes are there inside the body. If the level is less than 3, normal is 1 millimole per liter, but up to 3 is fine. If it is approaching or is going more than 3 and approaching 5, then prognosis is going towards worse. So, but if you are doing the treatment and lactate level is going down, it means your treatment is working and you can continue with the treatment. So that's why these 3 tests, along with the physical examination, that's a very handy tool, very handy for a veterinarian. Now see, this is interpretation of PCV and total protein, and that is changes. If you perform the PCV that is less than 40 and total protein is less than 7.5, then there might be colic is there, mild colic is there. No treatment may be required in such horses, and watch for any deterioration. But if the PCV is going up and is between 40 to 45, and total protein, plasma protein is 7.5 to 8.5, it means intravenous fluid need to be given, and rate should be 20 to 40 ml per kg per day, and you should continue to note down any deterioration. And if it is 45 to 55 PCV is there, it means dehydration is developing and the animal is losing the fluid into third compartment, and it means 8.5 to 9.5 gram per deciliter is the plasma protein. It means we need to give very high rate, 40 to 60 ml per kg, means if it's a 500 kg horse, we need to give at least 30 liter of the fluid in a day. If the PCV means, these 2 tests will tell you about how much fluid need to be given. If it is a more than 55, more than 9.5, it means we have to give at a shock rate 60 to 100 ml per kg per day. So we have to give at a very rapid rate. So now comes to the ultrasonography. So ultrasonography, that has little bit of limited use in diagnosis because of a lot of gas is there. Whenever there is obstruction is there, there is a lot of gas. When gas is there, ultrasound waves doesn't travel, but it helps to monitor. But otherwise, we can see the size of small intestine through ultrasonography. But if you want to diagnose a particular lesion, what lesion is there, that may not be able, you may not be able to find out through ultrasonography. But if you want to see the intestinal motility, or if the small intestine is distended or not, then then ultrasound can be used. But it can be useful in left dorsal displacement of large colon, or it can be useful in peritonitis as well. It can be useful in paralytic ileus, as well as post-operative monitoring. We can use ultrasonography. But if for diagnosis, just how we can diagnose left dorsal displacement, I'll tell you, I need to go back for that. Just for example, over here, so I told you that left dorsal colon and left ventral colon, it travels in between the abdominal wall. From here, it comes over here. When we put the ultrasound, these are ultrasound over here, and if we see the spleen, and normally, but in a normal animal, if we perform in the left side, left flank region, like in flame, so you will you will see the spleen, and after spleen, you can see easily the left kidney. But if there is a left dorsal displacement is there, spleen you can see, but after spleen there will be an intestine will be there, and left kidney can't be seen in ultrasonography. Means that can be a diagnostic for left dorsal displacement of large colon. Now comes to the problem here. There is always everywhere there is a contradiction going on whether this horse is good for medicinal treatment or we should shift to the surgical facility. That's horse. So if we do some parameters, Then this green parameters, it means the medicinal treatment is fine. The horse is alert and responsive, mild to moderate pain that respond to treatment. Heart rate remains less than 60 during the course of treatment and improve with the treatment. Means heart rate is going down. Pink mucous membrane, CRT is less than 2. Nasogastric reflex shows less than 2 liter. Color of peritoneal fluid is yellow and transparent. PCV remains between 40 to 50 and total protein between 5 to 8.5. It means medicinal treatment will be sufficient for particular horse, and there may not be and is responding to the treatment. But if there is a persistent recurrent abdominal pain not responding to treatment, indicate tachycardia with heart rate remains above 70 and injected mucous membrane, it means there is intestine sound. That's why a physical examination is really very important in a colic horse. Hearing the intestine sound, nasogastric intubation, rectal examination, these three things, if you start performing, and that can save the animal life as well. Abnormal finding is there in palpation rectal, like distended small. One thing is that in a normal horse, you should never able to palpate small intestine. If you are able to palpate small intestine, it means there is some severe obstruction is there. Means small intestines, they are highly distended. So normal animal, you can't palpate the small intestine, but in abnormal, highly distended. So cecal tympany is there, large colon distension is there, abnormal small colon findings. Small colon findings, they are very easy to diagnose rectally. So that's why if you found some fecalith, big fecalith, just cranial to the pelvic inlet where the small colon is there, then you should think about either even if there is a small fecalith is there, you can knead at that time, kneading can be done, but otherwise watch for that fecalith and start with the treatment and see the course, during course of the treatment, see whether that feculus has moved forward. If and it in a responding animal, it should move forward. But if it's not moving forward, then we might need surgery. So increasing preoperative means more than 55 PCVs there, and total protein is more than 9.5 gram per deciliter, and serial assessment of blood lactate. Why I'm stressing on the blood lactate? Because this is the very important tool. So which can differentiate between the strangulation and non-strangulation. If the lactate level is quite high, it means strangulation is developing. Then even the medicinal treatment is not going to help. So that is high and increasing trend is the blood lactate level is more than 7 millimole per liter. That shows a strong association with the non-survival as well. Means you can educate the owner as well. Look, that lactate level is quite high, more than 7. So your horse is having a very poor prognosis. So may or may not respond to treatment, and you can say surgery is the only option. So that may or may not. So that's why I'm stressing on the blood lactate level, PCV, and total protein. These three tests at least. So in conclusion, at the time of case presentation, do thorough physical examination and estimate the heart rate. Collect the blood sample, PCV, total protein, lactate. Start with the IV fluid and medication. How much of fluid need to be given? I think I already showed you a slide. Depending upon the PCV and total protein level, you can estimate that amount of the fluid need to be given in that particular horse. And so that if you need to give suppose 30 liter in a day, then horse, normally colicky horse doesn't stay quiet, that moves all the time. So giving 30 liter may not be easy. Tomorrow I am going to show you a video how to put a catheter, a human catheter into the vein, and that works wonder in horses, and even 50 liter, and that catheter can remain in situ into the vein for 3 days, 5 days, up to 5 days, and you can continue with the treatment with the fluid, and giving a lot of fluid, giving as much as fluid to the colicky horse can save the life of animal. Then repeat the physical exam, blood examination after some interval, depending upon the severity. Means if the horse is having a mild colic, then you can do the physical examination and blood examination after 12 hours or after 24 hours. But if it's acute colic is there and severe colic is there, then you might have to perform physical examination, and physical examination maybe after 2 hours, and blood examination maybe after 3 to 4 hours, so to see the progression. If responding, then continue with the treatment. If no response, then refer to the surgical intervention. So probably this is sorry for the delay, but I think it's a quite exhaustive presentation. So that's all from my side. If you have any queries, just let me know.
Thank you very much, Arun Anand sir, for your nice and wonderful presentation. Some queries are raised during the presentation. Yeah. I am asking one by one. Go through.
Yeah.
Sir, during the rectal examination, we found some straining in the ligaments of the colon. Is it related with the strangulation of the colon?
I mean, I can't just repeat what you are saying.
So during the rectal examination, we are experiencing some straining in the ligaments of the colon. Is it related to the strangulation of colon or some else other reflex?
You might have seen the applied anatomy. So I have not shown you any ligament is there. There is hardly any ligament is there. There are band is there. That too band is present in the cecum, which you can palpate. But in the large colon, either there is a distension is there or there is sacculations are there. If the sacculations, you can feel the sacculations, and it means you are on cecum, you are feeling the cecum. But if the band you are feeling and you are thinking that it's a ligament, it's not a ligament, it's a band, it's a normal structure. And if you are feeling on the right side, and though that band is quite tense, it means there is a distension of cecum is there. Either there is a gas is there, so gas of the cecum is there, or cecum, as I told you, is the 4th most common site of obstruction. So chances are there that cecum obstruction is there. So either what we can do is we can do trockerization, which I will tell you tomorrow seminar, that if there is a gas distension is there, we can do apply some needle as well, and we can evacuate the gas and again repeat the rectal examination and see what the status of that band is there.
Sir, what is the criteria to decide whether we will go for the surgical intervention or medicinal treatment for colic, and what are the precautions which we can take to prevent the peritonitis during surgical intervention?
I think that's the surgical intervention that will be dealt tomorrow seminar. Okay, so I'll tell you tomorrow. So how need to be done. So there are few steps are there while evacuation of the impacted part. So which I'll show you. I have a slide, so I'll show you on that. The first question, what was the first? Yes, how to differentiate? How to differentiate? The differentiation is here. So this is how you can differentiate whether medical treatment need to be given or surgery need to be done. It's all in front of you. Simple 3 tests: PCV, total protein lactate, proper physical examination, heart rate estimation, and nasogastric intubation. These 5 things will decide whether this is a medicinal treatment, the medical treatment is the best for that particular horse, or need surgery. Is it okay?
Yes, sir. Sir, can we use any vagolytic drug before rectal examination to avoid the rectal tear?
No, there is no need. Already the stasis is there. Intestine is not having proper peristalsis, and don't ever use vagolytic drug. Rather, go for lubrication of your hand with lignocaine jelly. That will be more handy. That will give local analgesia. The straining will be reduced. So that is more handy rather than giving any vagolytic drug. I will not recommend for that one.
Sir, how can we diagnose the gas colic ultrasonographically instead of per rectal ultrasonography or per rectal examination?
Yeah, I told you like over here, like it's a limited use due to gas. The first point which I told you that ultrasonography has a limited use. Only there is some windows are there. They are called ultrasonographic windows are there. There is one splenic window is there. There is one right kidney window is there. And there is one left ventral colon window is there. There we can do. But if there is a gas is there, then ultrasonography may not be a diagnostic tool. Only I told you the diagnosis we can do is left dorsal displacement, which I already discussed, peritonitis, paralytic ileus means if there is a intestine is not having proper peristalsis, or after surgery, if monitoring need to be done whether the intestine motility is normal, their ultrasonography is going to is a very handy tool. But if there is a gas is there, then ultrasonography is having a limited use for that.
Okay, sir. Thank you very much, sir. I am extending my sincere thanks to Dr. Arun Anand, sir, for giving us time and for delivering such a nice, wonderful, and interesting webinar on the topic etiology, anatomical consideration, and diagnosis of equine colic. I am also thankful to Dr. Simrat Sagar Singh, President ISVS, Dr. D.B. Patil, Executive Secretary ISVS, Dr. Nitin Bhatia, Intas Animal Health and his team, Dr. Divyesh, Dr. Neelesh for their support and cooperation to make this webinar a success. And I am also thankful to all the participants who have given us time to attend the webinar and upgrading their skills with the knowledge of Dr. Arun Anand. So thank you, each and every.
I just want to add one thing. So whatever the work we have done, so it is all because of the guidance of Dr. Simrat Sagar Singh.
Yes,
so
sir.
he's excellent in colic surgery. So whatever I have learned, so it's all because of him.
Yes, sir. Thank you very much, sir.
Okay. Thank you, sir. Thank you.